This is Metabolic Mastery, a KORR Medical Technologies podcast dedicated to advancing knowledge and practice in metabolic testing. Welcome to Metabolic Mastery, brought to you by KORR Medical Technologies. I'm Dr. Marc Humbert, and this is my co-host, Dr. Cameron Garber. And today we're talking about a little bit different of a topic. The topic is first, do no harm. And so why do we want to talk about that? What does that mean? So Cameron, let's talk about that concept in general. What does it mean? First, do no harm. Where does that come from?
Well, so that is like that is all healthcare, anyone in the healthcare. So physicians and other allied health professionals all kind of have that as their beginning directive is like, first, do no harm. So we don't want to make somebody's situation worse by intervening. And yet I would argue that we do that all the time, unfortunately, that we in ways in trying to be helpful often make things worse.
Absolutely.
And so we have to be careful in the interactions that we're having with our patients, that we don't actually make their situation worse by making them more afraid, more, less likely to move, less likely to participate, and more likely to just be passive in their health environment.
Absolutely. Well, so I think that misinformation and fear-based language are really big factors in how we can do harm. We've talked about this before, you and I. I want you to talk about what informed consent means to you. So this is one of the things that we talk about, that we give people informed consent in the medical world, sometimes in health and fitness. But what does that actually amount to?
They have to be aware of all of their options and what those things mean and how each of their options plays out both in the short term and the long term. A common example is orthopedic surgeries, and I have to be careful not to go too high up on my soapbox here. But sometimes what may provide the shortest, quickest relief for their current symptom actually opens up Pandora's box of, once you have one orthopedic surgery, you're on this now timetable of within 5 to 10 years of needing additional orthopedic surgeries. That's not ideal often. And if people knew that, they may not get the first one. Just going in and cleaning things up or looking inside your knee joint or shoulder joint or whatever to clean up some frayed articular cartilage and all of that. Now you put them on a cascade of, they're probably, statistically speaking, within 5 to 10 years going to need some additional surgery. And within, 15 to 20 years, we'll probably have a total joint replacement. So if you're a teen or 20 something or 30 something and they're just going in to clean things up, you have to be careful that even though it treated that symptom, is it doing more long-term harm? And so again, I have to be careful with that one. That's a soapbox issue of mine. But informed consent in that would be making sure that they understand all of the ramifications of this decision that we're making for their health and wellness, that it's not just to take care of this, but if I take care of this way, here are the consequences. If I take care of it this way, here are all of the consequences. I don't think we always do a good enough job at explaining all of those things and making sure that they truly do have informed consent.
So with informed consent, it's often just, what we think of it is, do this, right? Instead of, here are all your options. And like you said, these are the risks, these are ramifications, these are the benefits of going with any one of these things.
Right. So we often will have presented to us only the one option, and we may have the risks and benefits of that one option. We don't often have all of the options. Again, with the orthopedic example, when you look at a lot of the literature, when you compare sham orthopedic surgery to actual, like anything from rotator cuff repair, ACL surgery, meniscus surgery, things like that. When you compare them to sham surgeries, often the short-term outcomes are about the same. And the long-term outcomes are actually better if you have the sham surgery, where they just cut you open and sew you back shut. You actually have better long-term outcomes with meniscus injuries, with going in and just cleaning things up, and with rotator cuff repair, and even a lot of ACL surgeries. Most people do fine. It's interesting how the European literature actually suggests that the coping percentage of people that can be copers is actually quite high. And the US literature would suggest that the coping percentage is quite low for who can cope without having that ACL repaired. So kind of interesting there.
Yeah.
But not informing them of all of those different options.
Yeah. And so like the point is not to say, never get surgery. Surgery is bad, but it's can I understand the risks and both the short-term effects and potential long-term effects. And this is where those 2 points of misinformation and fear-mongering can really get in the way, right? If we don't have good information, how can we make good decisions? And some of the language that we use, right? This is, worn down, or, you can't do this thing anymore. Like that can really inhibit people from making the steps for their health that are actually going to help them improve.
Moving and participating in your life. When you use phrases like you're bone on bone. Well, if I go and have that surgery and you remove my articular cartilage, you're actually creating a true bone on bone situation.
Yeah.
Right. So that always is frustrating to me when it's like, well, you know why you're bone on bone is because that surgery you had 8 years ago, they removed or a big chunk of your articular cartilage. And so that accelerated that bone on bone process. Plus, you've always now considered that your bad knee, right? Quote unquote bad knee. And they warned you against running or other activities and things that made you more sedentary, more protective of that knee because of the language that they used. And so now you protected that knee and it actually did become more degenerative, not because of any disease process, but actually because of sedentarism.
Language can be super powerful. It's super powerful in terms of behavior, in terms of adherence. How well do we follow a plan? But it can also shape our physiology, right? My beliefs about what my pain means or what this thing means that can increase my level of pain, that can cause me to move in different ways. And so language can be really powerful in both good and bad, right? Using appropriate language, or at least neutral language, can help us to, get people adherent with plans of care that, again, are going to improve their health. And so, like you mentioned, we often use what we call nocebic language. And so that's fear-inducing or harm-inducing language. And so things like your metabolism, why can I not say that? My mouth is broken right now. Your metabolism is broken. You can't do this anymore. Your hormones are wrecked. Just those things really freak people out, right?
Oh, when you tell somebody stop running or don't do this activity ever again, or put restrictions on their lifestyle, that's really harmful.
Yeah. And so it can, like we mentioned, it can increase pain. It can reduce people's self-confidence, their belief that they can do things. It can, make it harder for them to stick to a plan long-term, because it's just like, oh, I guess this is hopeless. Like if I'm broken, then I guess I just don't try anything.
Well, it increases their fear avoidance. So they want to avoid anything that could potentially be harmful, even though pain in and of itself isn't necessarily harmful. That's a tricky situation, a loaded topic, I guess. But pain doesn't necessarily mean that damage is happening. And so we often do things to avoid pain when actually more damage is happening because we're avoiding that pain. And so we wind up not running or not exercising, not walking, not doing things because we want to avoid pain because we associate that pain with harm, when actually sometimes pain just means that there was tissue damage, and that as we continue to work through that pain will lessen, or as we decrease the forces on those tissues by increasing the strength and pliability and durability of those tissues, the pain will lessen with time. And so stable pain that doesn't get worse with activity, is actually just fine. And yet we often use language that makes people afraid of pain. And so it increases that fear avoidance and increases their sensitivity to that pain. And so they wind up less likely to participate in their own life and less likely to participate in the healthy behaviors that preserve their health and wellness.
Yeah. Well, I think what might be good to talk about is some of the former models that we used in healthcare, right?
Yeah.
So there's the biomedical model or the pathokinesiological model. And both of those are something happened. I injured my knee and that signal went up and now I have pain, right?
Mhm.
Or the way that I'm moving created this pain. And it was just this very like A leads to B line of thinking, right? And what we're coming to understand is that so many of the phenomena in our body, they're complex systems, right? We even see people on social media, right? They like to point to one mechanism, right? You got to avoid this because it's going to cause this. And in our body, like there are thousands of reactions co-occurring at any given time. And it's the summation of those processes that lead to different outcomes.
Yeah.
And so, pain itself, let's take that. Like pain is a very complex phenomena. And so the current model is the biopsychosocial model. And so it's, how is biology playing into things? How does that individual's psychology play into things? And then the social determinants of health. How do those all work with each other and map onto what's happening? And so pain, for example, right? My beliefs about what pain means, my past experience with pain, my sleep can change my pain, stress levels, fear-inducing language. This is what my pain means. Oh my goodness, right? That can change our perception of pain. And so I think that's understanding. It's like those signals coming from our tissues, they are real, but our brain is the master filterer, right? It's the creator of our perception. And so it's taking all these inputs and then creating our perception.
So what's fascinating with that a case example is like whiplash. Whiplash is a really fascinating thing to study. Most of the time with a whiplash injury, when you do x-rays, MRIs, and all the tissues look fine. So people, the worst of their pain. So the day after, obviously from that day or two after, you're sore and things are tender and sore and it hurts at a fairly understandable and normal level. What's fascinating is that the worst symptoms of their pain and not being able to move and being really like stiff and painful and everything hurts and I can't turn my head, that often doesn't come on till about the 2-week mark. And it often has perplexed people because it's like there's no physiological explanation for why that is. But it's usually as they start dealing with all of the fallout from the injury or from the accident, they're starting to talk to lawyers, they're starting to talk to their health insurance and all of these things. And the trauma of that event starts to come on. All of a sudden, their symptoms worsen. So it's really interesting that they're sore initially for the first day or two, and then things start to improve. And then at about that 2-week mark, that's when everything really starts to stiffen up, even in people who have no radiological evidence to suggest that anything physically is really wrong.
Yeah.
Right. And so I've worked with people who have this just irrational amount of pain to where, just a very light touch and they're like, oh my gosh, that
Yeah.
hurts so bad. And I'm like, you'll talk to them and be like, I barely pushed on you. Like I barely touched your skin. And it just sends, massive pain signals. And so the pain that we're perceiving from our brain is different than the stimulus that they're receiving. And so pain is a very interesting thing that a lot of that's often what we do for whiplash patients is things to talk them down off of that ledge of everything is heightened pain. And so it's reinforcing that you're okay, that everything looks great on your imaging. And so the tissues themselves are fine. And so we just need to reframe the way your brain is perceiving the inputs that it's receiving. And so much of what we do in rehab in general is just reframing our body's perception of the pain signals that it's receiving. And so pain in and of itself isn't necessarily harmful. Prolonged pain and intense pain and things like that can mess with our psychological health. And so I'm not saying that pain is just 100% fine and we should push through it. That's not the message. And there are different types of pain that gets worse with activity. That obviously is more of a signal that harm is being done. Whereas pain that's fairly stable, that doesn't change with activity, is actually okay. And we can continue to move and we'll see that pain lessen as our brain takes those inputs and goes, no harm was done from that. And so I'm okay.
Yeah. Yeah. Well, just that message of how do we reframe this, right?
Yeah.
It doesn't ignore what's happening, but it does try to put it in the proper perspective. And so, again, just being careful in how we phrase things and making sure that we're not using language that's going to increase that fear, increase pain, increase some of those behaviors that lead to people stopping activity or doing unhealthy things.
Right. And so we don't want things like false reassurance or toxic positivity
Right.
either. Of like, oh, you're fine.
Everything's okay.
Everything's all okay. And we definitely don't want to be like, oh, it's all in your head either.
Right.
Because it's our brain's perception of the signal doesn't mean it's not real.
Absolutely.
Their pain, even though it was a very light touch and it doesn't make sense with the input received, it's still real.
Yes.
100% real, because that's their perception of reality. And so it's 100% real. We just have to reframe what their reality looks like over time by reintroducing new movement patterns and sensations and touch and things that allow them to reinforce that this was safe, this was healthy, this was okay, and no additional harm happened. And so their brain can relearn those patterns. I
Yeah.
often use the example of, it's kind of like the RAM in your computer being reset and forgetting all the things that it had learned, so that you have to relearn kind of those quick actions within the computer to speed things back up.
Yeah. And as you mentioned, having, good sources of data can help with that reframing process. So you mentioned, right? Like we can take radiologic evidence and use that to tell a new story. Same thing with, someone comes in, my metabolism is broken, right? What's going on? And we can say like, well, no, your metabolism isn't broken, right? Even the language of your metabolism is slow can be unhelpful. What we can say is, hey, here's what the test showed. This is the way that your body uses calories, and here's how we improve it. And so it's being cognizant of reality, right? This is what we actually measured. This is what's happening in your body. And then using that to create the new plan, using that to create the new story, and help them see possibilities that are on the horizon.
Right. When we come to work with people for, metabolic disorders or just weight loss and metabolism, or even fitness improvement and performance, people come in with a lot of preloaded notions and a lot of either nocebo language or just a lot of learning of things that may not be actually true. And so we have to be careful at how we reframe that we use the data and evidence to show where reality is versus kind of what their current narrative is. And so that can be really helpful tool in reframing some of those either false impressions like my metabolism is slow, or that I need to be working as hard as I can. For an athlete, I need to be working as hard as I can all the time to make the most improvements. Being able to reframe that using quality data. And so that's how the cardio coach can help us do no harm, is by restructuring and reframing their thought processes to be more in line with what the data shows, the research data, but also their individual data shows.
Yeah. As we've talked about before, having that data is just neutral, right?
Is neutral. Yeah.
This is just what it is. And it puts us on the same side as the client, right?
Right.
Here, we're going to use this data and we're going to do that to make the next right decision for your health, right?
Yep.
And that becomes so important. And then I think one of the things that is really difficult for us as humans is uncertainty, right? It's like, I would rather know that I have cancer for sure than wondering like, do I have it or not, for example. And so being able to have that data and have those conversations can help people reduce their uncertainty. Like, oh, okay, like this is what's happening in my body. And these are the next steps that we're going to take, right? We have a plan. I know what this means. And so then I can take that confidence and go and apply that. And so I think that can be really important, as you mentioned.
Oh, absolutely.
All right. So next is, so we sometimes do harm through low value interventions and misplaced focus. And this is a tricky one, because one of the things that happens sometimes is this message is, it's like you either make lifestyle interventions or you take this medication or you do this modality, right? It becomes contrasted in either or. And we don't want to do that, right? It's like we can use different tools to personalize the training, the nutrition plan to that individual person. The problem is that we just kind of use that as a facade, right? Like, oh, it's not either or, it's both and, but then we actually ignore the highest value interventions and end up spending an inordinate amount of time on things that don't really move the needle much.
Yeah, we major in the minors, right?
Absolutely. And so, for example, like I'm going to do my cold plunge, but I missed out on my training session. I'm going to take this medication, but I'm not going to use that to leverage, things to help me exercise more. I'm going to take more lifestyle,
dietary lifestyle changes.
I'm going to take these supplements instead of working on habits. And so again, it's not that, some of those modalities are bad. Medications can be life-saving. They can be very helpful. Supplements can be helpful in some cases.
They can be additive,
but not foundational. So that's the difference. Additive, not foundational.
Yeah.
What's foundational? Those things that are going to carry the most of the freight of our health.
Right.
And so those are things like, what am I eating, right? What's my nutritional pattern? How am I moving? Sleep, stress. Do I have social connection, right? What's my environment like? Things like that are foundational and will move our health forward in the biggest ways. And then we add those tools in to help exponentiate what we're doing with those foundational things.
If I'm getting in the sauna every day and I'm very consistent with that, but I am missing out on regular exercise, I'm going to bed after midnight every night, and my social circle is really small, I'm not actually healthy, even though I'm being really good at hopping in the sauna every day.
Yeah.
Right. So that's the thing. Sometimes we focus and put all our eggs in one basket when it may not be the most important basket.
Yeah.
And so not that sauna is bad. It's just not going to have the same benefit as if you're combining that with all of the other.
Right. Well, I think one of the things that it can do is create false confidence or false certainty, right? Oh, I'm doing something for my health.
Yeah.
And so like, I don't need to worry about that anymore. I'm doing the thing. And again, it's not that that can't be helpful, but then does that cause me not to do the other things? And do I delay adaptation that could have occurred or that could have co-occurred because I've let myself off the hook with this thing?
Right. Cold plunge, sauna, or there's so many other modalities, red light and shockwave and so many other things that we can do that have some benefits or some ways to improve some aspect of our health.
Mm-hmm.
So all of those things can be good when it has that additive effect. But if it's replacing the foundational things, that's when it becomes harmful, even though it in and of itself may not be harmful, but if it's replacing that inner life. So that's the thing. It's that opportunity cost of the bigger things that's where that can be harmful in a way, because it's replacing the finite time that we have and the effort that we can put forth. It's putting that into something that's just not going to be a big needle mover. And yet we think we're doing the right things for our health. And I see this a ton. Like I have a client that was like, oh, I've been going to the stretch lab a ton lately and it's been really helpful for this thing and this thing. But then in the next sentence, they're telling me about how they've gained some weight and they've, these other things that are falling apart. It's like, it's not that the stretch lab couldn't be good for you.
Yeah.
But when you're putting you're taking your exercise time and going there instead, that can distract from the bigger needle mover options. And so it can be a good adjunct or something we do occasionally, but no one modality or one effort. Even you'll see this debate within the fitness world of strength training versus cardio.
Yeah.
And so that's when we talk about kind of that misplaced focus, it's neither one is the best thing to do. It's a balance of both that really helps us have the highest health outcomes.
Yeah. Well, and you see that, right? People that are really into strength training, it ends up putting blinders on us and we miss certain aspects of reality. And so you see this, like people are really into strength training. They're like, oh, I don't need cardio, right? My strength training is my cardio.
Well, I've got a six pack. Why do I need cardio?
Or on the opposite side, right? People that are like way into endurance things, but they keep running into injuries because they never do any type of strength training. And so like they're missing a portion of reality that if they had that piece in place would help improve their health markedly.
Right.
And so,
yeah, you've got bodybuilders who are dying in their late 50s and 60s, or endurance athletes who have to give up their sport early because of injuries. Either one isn't the perfect balance. It's having both that's the key. And so when we silo ourselves into any one modality or any one thing too much, it can do harm.
Yeah. You mentioned we don't live in a world of unlimited time and resources. We all have constraints on our time. And so what's going to give us the most bang for our buck ends up being really important here. And what are how do we discover the highest impact interventions, right? Because it's like maybe the next best thing is to increase strength training, or maybe it's to redesign our aerobic workouts, or, whatever that's going to be. If we can find out what those limitations are, then that will help us to take the next right step.
And that's the key. Finding out what are my limitations. And that's where a cardio coach can help.
Yeah.
That's where I can step in, is testing the
Absolutely.
right things, find out where am I from a, strength standpoint. We can tell a lot about somebody's muscle health from a VO2 test. We can tell a lot about their mitochondrial health from an RMR test. There's a lot we can understand about someone's overall health by getting testing done. And so it informs that decision making better.
Yeah. So this is actually, we recorded an episode a little bit back with Daniel Crumbach that talked about identifying limitations with physiological testing like this, physiological VO2 testing. And so, like to Cameron's point, we can look at what's going on with the efficiency of the musculoskeletal system. Are there cardiovascular limitations? Are there respiratory limitations? What's going on? And so once we understand this, then we can say like, okay, well, priority, right? What's the first level of priority, secondary, tertiary? And if we work on this one thing, we'll actually improve all these others. Or can we work on these simultaneously? Like having that good data really helps us to map out a good plan that recognizes their constraints, their limitations, and then works within those to move their health forward.
Yeah, and that's the key, is making sure that we understand that individual well enough. Because one of the other big factors where we do harm is by creating a poor exercise prescription. So when we create a poor exercise prescription, if we build them up too quickly or too aggressively, we wind up causing burnout, injury, and high rates of dropout. And we see this all the time when people visit personal trainers or exercise physiologists whose goal is like, I want to make you sore. They see that as a badge of honor. And the problem with that is you may have given them one good workout, but it may be that you only gave them one good workout and they never come back again, or they're less likely to be consistent with it. And the problem is exercise is not about one workout. I would rather people halfway do their workouts, but do it consistently, than have one great workout a week and then recover for the rest of the week. And so that's the thing. What can we do to allow their body, their tissues to get used to the increase in loads so that they can stick with it, that they are not too sore? Some soreness happens occasionally, and that's okay, but we don't want it to be a level of soreness that discourages them from participating. We don't want it to be a level of exertion that discourages them. Instead, we want it to be motivating and exciting, because the right thing for their body at the right time, that's building them up in a way that helps them to feel encouraged and stronger and less fatigued, not more fatigued. If your workouts are fatiguing you, we need to switch things up. It's too much too soon for where you're at. Your workout should be pretty invigorating, where you may be tired at the end of the workout, but after a brief recovery period, you actually feel better for the rest of your day. If you're feeling tired and fatigued and beat up for the rest of your day, it's probably too much too soon.
Yeah.
Doesn't mean you did too much for what you will eventually be capable of, but it's probably too much for where you're currently at. And again, this is where good data comes in, is we can test somebody and find out where those limits are. That's why zone 2 workouts are so important, is we can test somebody and find out where is their right now effort level supposed to be for maintaining the low intensity phase as well as the high intensity phase. Where does that need to be right now?
Yeah. So I'm going to take a little aside because I want to point to something with understanding heart rate zones, because you mentioned like zone 2 can help us to get that low intensity effort that's going to drive fat adaptation, that's going to allow them to make progress without overdrawing on their recovery. And that's one of the things that we've talked about. Training across the heart rate zones, but emphasizing that low intensity helps us have that balance of adaptation with sufficient recovery. And it goes right, like some people will poo-poo on high intensity. There's people poo-pooing zone 2 right now. Here's the problem, is that the way that zone 2 is often defined, no wonder it's ineffective, right? No wonder it's actually zone 3, right? Like we're not training at a level where we're having high recovery and also high stimulus for adaptations of our oxidative energy systems. And so we end up comparing apples to oranges, right? Well, zone 2 doesn't work. Well, it's like, yeah, but that's not actually zone 2, right? You're not working on that zone. It's right. Zone 3 or higher. And so, well, yeah, we're not going to see those adaptations because you're not training in such a way that's going to optimize for those adaptations.
Right. That is one of the key differentiating factors, and why I personally believe that you can't just have 2 data for setting heart rate zones that you need CO2 data as well to really accurately set heart rate zones, because you're more capable of seeing where is that primary fat oxidation
Absolutely.
zone, so that we can set a more accurate zone 2 where people are going to be more likely to have success with their training, because they're more likely to stick with it because it's easy enough that it's less taxing on their body for the base of their, or the bulk of their base training. And then they'll have more gas in the tank to push harder when they go into zones 4 and 5, so that they actually get more adaptation signal with less likelihood of injury. And so,
Yeah.
I'm a big advocate, we've talked about it before, of the 80-20 training regimen, that the volume of your total volume of training with any given training period fits within that 80-20 range, 80% zone 2 and 20% zone 4 and 5, and kind of avoiding zone 3 altogether, the lovely no progress zone.
Yeah.
Unfortunately, most people and most exercise prescriptions have people spend the majority of their time in zone 3, which is, it's too fast to really be a good base building, aerobic building zone, but it's also too slow to really push and drive adaptation.
Yeah.
It's not fast enough to change the metabolics and mechanics of speed. And so we wind up being in this no progress zone, that this zone of not really creating the type of adaptation that we need, and being a much higher risk for injury and fatigue and burnout.
Yeah. Well, and that's why those high intensity workouts become so enticing, because after plateauing for so long, now I'm seeing improvements, right?
Yeah.
But we made this point before, like, it's not that like 80-20 is this magic number. It's just that seems to be the amount that allows us to get the adaptation, to progress over time, and then to stay in the game.
Absolutely. You can progress more quickly with a 50-50 or 60-40 or whatever. You can progress more quickly. Your likelihood of injury is multifold higher. So what they found is that 80-20 is the best for avoiding injury while still maximizing adaptation. That seems to be the amount of adaptation that we can derive while still staying safe. So often within somebody's overall plan, they will have weeks where they're closer to 60-40, 70-30 for a period of time, for a period of days to a week or two. But then they'll have on the back end of that a recovery period where they're more like 90-10. So that the total balance of any training period is 80-20. And so it's okay to peak for a couple of weeks if we give our tissues a break for a couple of weeks as well, where we're still training. I say give our tissues a break. We're still training, but we've just switched the intensity focus to be a little bit less intense and a little bit greater volume of that low intensity based training.
Yeah.
That really shouldn't, if we're going slow enough, train into injuries, because
Yeah.
it's well within our capacity to operate. And that's the idea. And so by retesting, we can find out, has that capacity shifted? Has my zone 2 grown over time? And we often do see that when people stick with that,
Yeah.
that their zone 2 grows, that we can go higher into our heart rate range, and it feels like it did at a much lower heart rate before, that we're able to create more work, that we're able to produce more work at a higher intensity and have it feel like it was less effort.
Yeah. Well, and I think just having that data is so nice because it reflects what's happening, like how our body uses energy, right? How's our body shifting between its different energy systems? It anchors it to physiology. And this is one of the problems that we see with training prescription, is that it becomes divorced from physiology, right? Like, yes, it might lead to quick adaptations, but what happens with recovery? What happens over the long term? And so when we have an understanding of some of the basic principles of physiology, we can see like, oh, like, yeah, that makes sense why this is effective, but is that going to be effective over the long term, right? Is that really the best for this person? And so developing some of that understanding of physiology helps us to mesh training and physiology back together in such a way that we can see what's happening in the individual, right? We get the data from the individual, we take what we know about physiology, and then we combine that to create a training program that will optimize for the adaptations that we're looking for, and that will help the client be adherent. Because that's one of the big difficulties is, like, I might have the quote unquote perfect exercise program, but if the person doesn't do it, then it's not the perfect exercise program.
Right.
The best exercise program is the one that the person will consistently do, and then we can retest. And again, like we retest to see, are they making progress or are they not? Is there something we need to switch? In their workouts, are they able to progressively overload, right? I'm able to lift, heavier weights for more reps. I'm able to, tolerate more time on my feet. Looking at those factors and then looking at the data that we're getting from the testing helps us to turn the dial on those decisions. Do I need to increase, decrease? Do we need to focus a little bit more on strength training? Do we need to build more of the aerobic base? Do we need to sprinkle in a little bit more of that high intensity? Where are they at? And what have they earned the right to do given where their physiology is at?
Right. And we can use their heart rate then as that daily barometer of matching their stress, their current capacity, so that we can really dial in the true goal, which is not, I want to train as hard as possible. The true goal is, I want to train as sustainably as possible. And so using those heart rate zones to say, this is how hard I should train on any given day. And if I'm just having a bad day and my heart rate is high relative to other days, honoring that and sticking with that allows us to be more consistent and have more training days, more time under load, which is going to drive greater change, greater adaptation, because I have more time under load. And it just allows me to accumulate more load, which drives more adaptation, which drives better improvements in health and wellness and fitness and all of those things. Whereas I do harm by not having those things dialed in and creating an exercise prescription that isn't based on the individual, that is based more on, this is what Arnold did. I remember when I was in a high school weightlifting class, one of the kids that was juicing at the time, he was huge and jacked, and I was this skinny little kid. He was telling me to go buy a magazine. I think it was like Muscle Magazine or whatever. It's like, just grab one of those magazines and find one of the workouts in there, and just follow that workout plan. It's like, yeah, but I'm not Arnold. So starting with what Arnold is doing now, me starting there is probably not a good idea. I kind of had that realization then of like, yeah, that's cool, but I'm not one of those guys. And so we often see that where people do that thing of finding their favorite influencer and doing the workout that that influencer is doing, or finding their favorite runner and doing the same running workouts that their favorite runner is doing. The problem is they earn the right to do that over time.
Yeah.
And they've been consistent for decades usually. And so they've earned the right to do that workout at that training volume, at those intensities. And so that works for them and they don't get injured because they earned the right to do it. If I start at where they have earned the right to become, it's usually not going to work out well. And I'll get burned out, injured, or fatigued and drop out from it.
Absolutely. I just want to point out really quick something that you said about sustainability. Sustainability does not mean that we don't get to have high effort. It just means that high effort gets put in its proper place as part of the overall plan. There may be days that we still work very hard, but it's in a way that selects for sustainability over time.
Well, we wind up being able to work out even harder.
Yeah.
We just earn the right to work that hard. Whereas when we try to work out really hard before we've earned the right to, we just wind up getting injured or burned out.
Yeah. So one last point we'll hit really quick is harm through over restriction or fear of movement. So we go in and I have pain, my knee hurts when I run, I do this. And the advice is you stop running, don't hike anymore, stop that sport. That's too much wear and tear. And what that does is it disincentivizes movements and sets people up for increased sedentary lifestyle and all of the risks that are associated with that.
That's exactly. And that's the problem, is you wind up setting them up for long-term failure with a lot of these things. When we increase their fear of movement or their fear of failure, by getting them on the wrong exercise plan that's not based on their body, then they develop a fear of failure versus a fear of movement. But it's all kind of related, in it becomes, we avoid those activities because we don't want it to chalk up one more thing that we haven't succeeded with, or one more thing that causes me pain or discomfort, or it can even be gym intimidation that we're avoiding.
Yeah.
That I started off too soon in the wrong environment, and now I'm afraid of being around the spandex crew that all seems to know what they're doing in the gym and I don't. And so we have to be careful how we phrase things, how we introduce people into the exercise world, that We do it on their terms and according to their physiology so that we're not using phrases that discourage them and things that encourage them. So whether it's telling people to stop running, if somebody tells you to stop running, run away from them. That's what I always tell people. Running is actually one of the healthiest things that we can do. It doesn't wear out your knees. It doesn't, there's actually less arthritis in runners. There's less knee pain. So we can train into some of these things.
Yeah.
But on the whole, runners that don't overtrain actually have fewer pain and problems and symptoms than just about anybody else. And they've even shown running to reduce or change arthritis, to reverse arthritic change in knees, as long as we get the intensity and the volume correct for that individual. And so we have to be careful when we over restrict and kind of prescribe the wrong plan of care that restricts movement versus saying, let's modify movement
Absolutely.
to where you're at and keep you moving. And we're just going to change up the way you're loading that tissue until that tissue has been able to build back up. And so that's often people I hear all the time, like, oh, my car accident from when I was a teenager. You are not still suffering from the effects of that car accident when you were a teenager. What you may be suffering from is your avoidance of using those tissues for decades because of that car accident. And then now you've got an inherent weakness and other problems. But if we had strengthened from day one and utilized those tissues appropriately and built that back up, our tissues heal, our body heals. It replaces itself on a fairly regular basis, and we can fully recover from just about any injury. There are athletes walking around with, ultra marathoners who run 300-mile races that have 6 levels of their spine fused. Things like that. Our body can recover and adapt to just about anything if we allow it enough time to adapt and change. You watch the Paralympics, for example, and there are people with massive asymmetries, massive, you know, things that aren't normal, quote unquote, normal physiology, and yet they can accomplish amazing athletic feats with little to no pain and little to no restriction because they've allowed their body to adapt slowly over time. They've applied those loads to their body slowly enough over time that their body has made those adaptations and they're totally fine.
Yeah. What are their constraints? And then how did we work within those constraints to move to the next level of
Yeah.
performance? And I think really the final thing is we're often quick to give advice and slow to ask questions. And I think we need to flip that. Be quick to ask questions and slow to give advice. Make sure that you understand the individual in front of you. Make sure that you're taking a look at the data, asking questions of the data, asking questions of the client, and combining that to help you give the best tailored advice that's really going to matter for their situation. So someone comes in and says, oh, this hurts when I'm running. Oh, well, why? What type of running? How fast? What speed? We're going more into what creates the constraints. And then that gives us understanding in how to work within those constraints to move them back into health, to recover their tissues, to increase performance.
Right. Stop giving advice based on guesswork and give it based on quality data.
Absolutely.
So do the tests, ask the right questions, use that quality data to then make the most informed decision and give that patient the most informed consent, to bring it back to where we started, so that we're not making their entire life by telling somebody to stop running or stop lifting or stop doing overhead lifts. My father-in-law was told by a physician to stop doing arm exercises because it can affect his shoulder. And I'm thinking, well, now you have affected his shoulder because he's not going to do those arm exercises that stress the shoulder. And so now his shoulder becomes weaker, and he's a tennis player and pickleball player and volleyball player where he does a lot of overhead activities. And so now you're avoiding overhead exercises and bench presses and things like that that help keep the shoulder healthy and strong.
Yeah. Yeah.
And so you've actually done more harm by telling him to avoid some pain and discomfort. You've done more harm because now you're predisposing him to greater injury that can happen because he's avoiding strengthening that and maybe a little bit of discomfort for now bigger changes in weakness and dysfunction that will lead to larger injuries and more problem over time.
Yeah.
So we have to be really careful with our kind of modern interpretation of do no harm. isn't like leeches and bloodletting and some of those other things that I think that's where it was like, whoa, we need to maybe back off some of these
Yeah.
things that are just experimental and do no harm. Now it's more avoid fear-based language, low volume, low impact distractions. I mean, low value distractions and things that are unsustainable, that are going to just lead to burnout, fatigue, injury, and unnecessary restrictions. So our
Yeah.
job really is to reduce those barriers and to empower people to build momentum in a safe, effective way that increases their confidence and builds a healthy lifestyle.
Absolutely. Well, really, the most harmful thing that we can do is convince people that they're fragile.
Absolutely.
It can do so much harm. What we want to do is help people understand how capable they are, how adaptable bodies are, and that they can do this. They're not broken, but that we just need to take the right steps at the right time to move that along, right? To build momentum and make sure things are sustainable so that they can really experience long-lasting health.
Yep, that's the key.
Yeah, awesome. Well, thanks so much for joining us. As always, if you want more content like this, remember to like, follow, and subscribe, and we'll catch you next time. Ready to take your metabolic testing to the next level? Visit KORR.com to learn more about purchasing our metabolic test equipment.